All right, so yeah, so Charlotte asked us to really bring the sort of One Health approach. Now, why do we, Simon, Hans, and myself, have any right to do this? I got involved. I've been working now in my field for 42 years, so had a long career, but it's been primarily focused in Africa and Asia, actually, not so much in Europe, although I have interacted more in the last decade since I took up this professorship at the Royal Veterinary College. So I've had much more engagement with the European colleagues, which has been actually a real pleasure, late in my career. But I got involved, really as a frustrated conservation health person, really, back at the turn of the century, just seeing that nothing seemed to be working really in terms of the environment, biodiversity, and also health issues around wildlife. And I went to a meeting where there were some really innovative people back in 2003. It actually was a congress in South Africa, and it just brought people together who had like minds. And so a thing called the One World, One Health movement sort of developed from this. So it was mostly conservationists. And it led to, actually through colleagues in New York at the time, to a thing called the Manhattan Principles, which were really just looking at a lot of these environmental and biodiversity issues in the context of overall human priorities. And it sort of, it attracted a lot of attention. People, I think we were, in the 21st century, people were very uncomfortable. So it sort of, it stimulated this thinking. And from that, actually, the One Health gradually sort of emerged. Again, lots of agendas and the main sort of health sectors, so the WHO and the Food and Agriculture Organization and the World Animal Health Organization, sort of called the OIE, Organisation Internationale des Épizooties. So these got together, and they rather sort of cornered the market. And they, in fact, the One World, One Health movement was trademarked, so they couldn't use that. And sort of since then, we've got other names that are sort of attached to this sort of general concept. Anyway, we'll discuss some of that. But so that's really my, I guess, since then I've been engaged. So I've been engaged with a lot of the agencies. I've been engaged academically. And through the sort of voluntary work that I do, I sit on the International Union for the Conservation of Nature, looking at specialized in the wildlife health frame. Yeah, so we try and push it forward, and through my contact with the Europeans, it's through the NEO project, which Simon will talk a little bit more about. It's sort of become it's become a bit more formalized, and it's still evolving. All new paradigms, they go through this, I think. So what matters about One Health to me? Well, being a health person, I sort of worry, that we're really not dealing with these health issues. So we've got what I would say is broken health system. So it's easy to throw out terms like this, but I'll try and justify why I say that. And then, of course, for you, is this approach, is this paradigm relevant? And I think that's something you can decide afterwards. All right, so I'll talk about the state of health and broken health systems. I'll talk a bit about convergence so in other words, this is not new in a way. A lot of people have been thinking this way for centuries, actually, but not listened to on the whole, or they just end up being sort of submerged through other ideological processes. But I think this recognition of the human impact has been there for a long time. It's sort of like an ant's nest, how do you actually get a change? How do you get them to change behavior? Very difficult, actually. And then, okay, where are we in One Health? So I'll talk a little bit about that. And also talk about, well, if we're going to use it as a paradigm, and this is where I think NEO has been really good, and I won't dwell too much on that. Simon will talk a lot more about that, and Hans. But how do we implement and measure this paradigm? So we'll come on to that. Yeah, so just very quickly, because this will be repeated. We have this term eco-health, which has sort of become a bit more popular, and it's a sort of shortening of ecosystems health, which originally was around in the 1970s, sort of time of Vietnam and all that lot. It was very trendy, to be talking about these things. And it sort of, then we ended up with this sort of eco-health movement and this international association of eco-health. Anyway, they're all emerging disciplines, really. And where they circle around is links between animals, humans, and ecosystems health. And actually, ecosystems brings in plants and fungi and all that sort of stuff, soil organisms, etc. So really, it's life, really, we're talking about. But why? So really, it was in recognition of crisis. So, we've been getting into one crisis after another, sort of human condition, really. And part of this has been disease. So, and, the question is, why is this happening? Is it environmental degradation, human behavior, lots of other ecological changes. So that's where this whole thing about complexity comes in. And so we'll talk a little bit about that as well. I went to a lot on that, but Hans and Simon will bring that. And then this idea of transdisciplinarity. So it's a bit like us talking today. We've got to understand each other. So we do need to use language we can understand. So it took me a while to sort of get my head around transdisciplinarity. But so the idea of that is that you actually communicate. You actually speak a language. Disciplines, in order to get their sort of royal charters and things historically, like professionals, like I'm, a professional veterinarian originally, I have that sort of privilege. I can sort of wear a gown and a funny hat, and I'm sort of given this status, and to protect that status, I invent a language, and often, you often use an old language like Latin, and we talk about encephalitis, and a lot of people don't understand what that is, but it's just inflammation of the brain. So, we don't use ordinary language to communicate. So I think transdisciplinarity is to get a language that, we can communicate, we can understand each other. So bringing together all these disciplines, we have to actually break that barrier first. Of course, there's a lot of academics in this, and I think it has been primarily driven from academic communities. But I think there is also a bit of a groundswell, where people are beginning to talk to each other a bit more. Yeah, so this is one definition. So you'll see a whole bunch of definitions, but the idea really is to resolve some of these issues, and the question is, can it do that? What worries me about the way One Health actually emerged is that it got sort of grabbed and put into the agenda of those professional sectors. So human health, animal health, planetary health in the agricultural context. In other words, a lot of the planet is about what we do with it for our own nutrition. So, massive amount of the planet is transformed for agricultural purposes for human beings. And so FAO, Food and Agriculture Organization, in a sense, it also is a sort of profession, and production is its main interest, food security. Okay, but in doing that, we've caused an enormous ecological change on the planet, and it's this is something we mustn't underestimate. So these sectors sort of cornered the market, but many of us have been sort of fighting back over the years to try and keep it broad, keep it outside actually of the professional sectors. And I think the broad vision is to bring, all things public, animal health, food safety, climate health. I mean, climate and migration health. I think they should all be in here. And we really need to have something practical come out of it. And I think that initially must be a more balanced investment between human, animal, and environmental health effort, including plants. So really, it's this whole healthy planet, healthy people. This is what keeps us going, is a planet that works. And currently we sort of ignore that. Yeah, so vets and medics have been important in the process, but by no means should we be in control. It's really whole of society that needs to deal with this. So I just want to get that fundamental message across. So is there a problem? Again, people say, with academics in particular, we're always looking for problems to solve. And maybe we just generate it. Now, Najmul Haid is a postdoc of mine. He's a Bangladeshi colleague, and he did his PhD in Denmark. But he's a really nice guy. But he comes from a background of really understanding problems. So Bangladesh is from a climate perspective, a very, very vulnerable country, and it gets a lot of help. associated with being essentially submerged, and it will become increasingly submerged. And things like mosquitoes, he did his PhD in mosquitoes. But anyway, he sort of got into modeling and all that sort of stuff. So over the COVID, because as academics we were sort of grounded, and a lot of my research projects we couldn't really get out into the field and so on. So we sort of oriented to COVID and joined research consortia and began to sort of try and develop some ideas around it. So so one of my ideas was, well, okay, what is the problem in a sense? Why is this COVID thing happening? So what we decided to look at, and I had been involved with David Heyman and Chatham House, I sit on their advisory sort of research community, is this global health security agenda. So this is an agenda that involves, I think, only about 75 countries, not enough actually, but they're sort of more powerful countries who set this agenda as to the threats from disease and health. So anyway, one of the things that they set up was the Global Health Security Index. Okay, so it's a comprehensive assessment of global health security capabilities in 195 countries. So that was actually quite comprehensive. And so that was a sort of useful thing. And then as part of the international health regulations, there's this thing called the JEE. Maybe you've been involved with JEE, I don't know. But it's all about country capacity to prevent, detect, and rapidly respond to public health threats. It doesn't matter where they come from. And it was sort of to measure country specific, to encourage those countries to come up to a standard. And so this is really what the problem, I think, is fundamentally. So this is now the analysis that we did. So we looked at the index. So the GHS index on the left and the JEE score. So really, if you do well and you have a high index, you should have your total deaths per million. This is relating to COVID, somewhere low down. Okay, so this is where you should be. But if you look at so many countries, and the acronyms here are ones that I think I don't need to spell out for you. But if you look at this, yeah, you've got an enormous number of deaths, and yet you've got the highest global health security index. Similarly for the JEE, okay? So what is wrong? So I call it the COVID paradox. So there's something wrong. I mean, in other words, we measure our health based on these things and our ability to respond and deal, our preparedness, if you like. But it's back to front. It's not right. It's not working. So they don't have a good predictive value. And so when we thought about this and in that publication, we said, what's wrong is that the index is wrong. We don't measure healthiness correctly, and we don't measure our preparedness correctly. We don't measure our vulnerabilities. And One Health can help you do that, because it puts you beyond, if you like, technical medicine, technical health, and puts you into a sort of frame of a much more sort of global concept of health. And really what it comes down to is the more developed countries, okay, so we call them developed. I hate the term, because actually it leads us into, I think, this false sense of security and complacency. And actually developed is not a great place to be in the context of COVID. And I imagine this is going to be repeated over and over again. We really have become an unhealthy society through development. So there's something wrong with development, actually, and the whole, our political economy really is fundamentally at the root of this. So we need a reappraisal of the system. And unless you do that, unless you get an index which you can follow, in other words, the development pathway that actually makes sense, we're only going to get ourselves into more and more trouble. Okay, so that's a bit of the evidence. But actually, you all know. I mean, Stefan did this really excellent thing, showing all the exponential changes that are, catastrophic for us on this earth. So it doesn't matter which way you look, we're on the wrong path, folks. We really are. So I think we all agree that 8, 9, 10-year-old children understand that. We don't need to be academic about this. So the question is, how do we change that path, really? Now, people often talk about population growth. I don't think this is the big issue, actually. A lot of people say that, but to me, it's more about how you behave as a population, and in effect, what your political economy is with that population, not the population per se. And that's why we tend to focus on Africa and say Africa is a basket case because it's just growing too quickly. But actually, if you look in terms of COVID, it's been incredibly resilient because it has a normal biological structure. It has a lot of young people. a lot of resilience in the system. It's not developed. And then, of course, we have the climate issues. I don't need to dwell too much on that, but it's clear that there are only a few countries, 20 countries that really matter in this story about climate, and they're the ones that need to sort themselves out. Not 195 countries, just 20, and you can see where they are. It doesn't matter where you look. Consumption patterns, amount of bottled water consumed. It's really development which has led us into this problem. And then we've had lots of really interesting, ideas, Rockstrom, etc., in relation to planetary boundaries, and so some great concepts out there. But let's come back to sort of just basic things like death. Okay, so what causes death? And what's interesting is I work in the infectious disease world mainly, but it's not the biggest problem by a long way. It's the non-communicable diseases the biggest problem. So you really have to look into and the predictions and so on. Well, of course, infectious diseases come back up a little bit, but in overall impacts, it still remains not the biggest. And sadly, of course, even though infectious diseases are tending to come down, actually, these other things like mechanical injury, in our sort of technological world, are increasing. So prevention, preparedness, and response. So this is what it's all, this is where the global health security agenda is focused. And I mean, what's interesting, this is a WHO report. If you're interested, you can read it. It is anticipating emerging infectious disease epidemics 2015. Okay, so this is what happens in these sort of big, international organizations. They have these meetings and so on, and they talk about, well, what causes pandemics, right? And so we have this classic sort of picture of the bats, of course. You've got to be bats or rats or something like that. And being a wildlife guy, I get so mad about this because these animals have been around, a lot longer than human beings, and they don't spread a lot of problems. They just get on with life. Humans create these huge domestic animal populations, and now 96% of the mammal biomass on Earth is actually agricultural. It's domestic. We've destroyed nature. I mean, the poor bats and the monkeys, and they've just been absolutely smashed by what humans have done to our environment. And of course, those very monotypic animals end up being a fantastic sort of factory for pathogen evolution. Anyway, we talk about that, and so we get this sort of process. They say, oh, it spills over from nature, and then it comes through to, we get these sort of epidemic cycles, and eventually you get up with pandemics. Okay. I mean, things have to come from somewhere. New pathogens have to come from somewhere. But actually, it's the attractants that matter. In other words, it's this that matters. And in the same meeting, of course, people sit around tables and they all talk about it. I mean, we sort of all know basically what's going on, but actually doesn't make any difference. No. So what do we look at? Food systems. All right. So we have to look at these systems we have. We have to have a systems thinking. And until we do that, we don't really get to the roots of all these health problems, these diseases that emerge and arise, of which coronavirus is just another example. And are emerging infectious diseases really a big issue? The whole term is confusing, and it really needs to be sorted out, because it covers a very wide range of things, from odd variants, from antimicrobial resistance to maybe the first time a disease has been spotted, maybe there's a new diagnostic test. It doesn't actually tell us a lot about what is really happening in terms of emergent pathogens that, in a sense, haven't been around before. So that whole field needs to be really sorted out. And I'm afraid there are a lot of agendas that have driven these things, and also this whole wildlife as a source agenda. I'm afraid I'm very, very, very unhappy with. Things like the 70% of all emerging diseases coming from animals and wildlife. In reality, if we really want to define emerging infectious diseases as this sort of broad category, which doesn't really make a lot of sense, it's actually about 43% of human emerging infectious diseases have some link to wildlife, but it's probably historic, evolutionary in a sense, not a direct effect. And we published, about COVID, because everybody talks about it as a zoonosis. But we don't get it from animals, we get it from people. And really, are these coronavirus epidemics that novel? I'll just take you back to this particular virus, OC43, which with retrospective analysis takes us back to the plague of 1892. And it looks like it was very much similar to to our current coronavirus outbreak. It was called Asian flu. We didn't have the tools then to look at these things, and it probably came from cattle. Okay, so these things aren't new. And wildlife is a source of infection. I had to use a log scale here. So this paper I put out in 2014, just to show, if you look at something like rabies, it's a nasty disease of humans. 99%, probably 99.9% of all rabies cases come from domestic dogs. And yet we talk about bats and rabies. You get a tiny amount. In the United States, you get 2, maybe 3 cases a year, where it might come from a raccoon or some sort of unusual contact between humans and one of the maintenance hosts for the virus. So wildlife is really not direct infection from wildlife, extremely rare. Okay, so don't worry about nature. This is a thing we developed with colleagues some years ago about trying to get people to get out of this emergency medicine area. In other words, everything's in emergency medicine. Everything's about treatments and cures and blah blah. But actually, that's not the key thing. We need to get deeper. So One Health, it's about looking at the global situation of health, structural One Health, which I'm very, very keen on, which is looking at the fundamentals, the political economy behind all these things. So how do we implement One Health in practice? Lots of different ways to do it, and my colleagues will talk a little bit more about this. So that's fine. Things that interest me are to get some simple, practical ways to tie the world to One Health. And to me, it's simple things: soil fertility, air and water quality, biodiversity, microbiome, okay, which is really all about biodiversity, climate. Yeah, it's a good indicator. And global burden of disease, I think, is also a good indicator. So, and then ultimately, if we use those indicators, then we try and have an equitable delivery to health, not just to humans, but also to the animals, the plants, etc. that we live with. So disease is really a construct of humans. Natural ecologies, they have disease, but it's really in balance, and it's not really a major issue. So just to finish now, so we have time to talk. In primary healthcare of migrants, so of course migrants are a special case. I'm a migrant, actually. I was born in what was then a country called Rhodesia. It's now called Zimbabwe. I was caught up in a conflict between the colonial community and the indigenous communities. And it was tragic. My family was all caught up in that, and I became a migrant, and I came to Europe because I had European origins through Afrikaans parents in South Africa. And we had to be naturalized. So I came the same route as Somalis and Syrians and so on. So I'm a migrant. So I understand what it is to be a migrant, but I feel pretty privileged migrant. It wasn't that difficult, although it was quite tough for my family and so on. It wasn't really a case of walking across African deserts and getting into boats to get across into Europe and so on. But I understand at least something about what was involved. So I think for this, you need to consider the structural issues. In other words, take you back to that pyramid idea that we need to look at the roots of these things. Of course, climate is one of those, but exactly what proportion of the effect is climate, what proportion is other things is where we need to actually really use One Health to use the complexity and the sense of the system and understand what the primary drivers are. And obviously in the process of trying to manage this, we've got to think about the basic needs, if you like, the needs for life. So that this idea, those parameters I say are important for One Health: clean water, availability obviously of food, availability of cash, the effects of infection, stress effects, malnutrition, lack of shelter. So in other words, these are things you'll be very familiar with, but it's bringing them together and trying to analyze them and to identify where mitigation can be most effectively done. And of course, remember, the environment provides most of these things. So, if we degrade the environment, we create a real big problem, whether it be for migrants, for anybody. So we need to think about, the consequences in a sense of how we degrade our environment for the future. And then we need to bring in the political, economic, and other ecological issues. Attitudes. Attitudes are so important. Narratives are so important to how people are treated. This aspect of society, I think really needs to be resolved or improved anyway. And obviously regulations, enforcement, authority, how we use that. And then probably one of the most, I think, most important things in a sense relating to migration is the attractants for migration. Migration is not new, and it's about people's perceptions and also the problems that they have at home. And so the perceptions that things are better, greener on the other side of the fence, which are really, really important in the migration story. And NEO, my colleagues will talk a little bit more about NEO. And I think that's enough from me. I hope that gives you a sense, but you probably want to know some of the real technical aspects, and my colleagues will be able to give you a lot more of that. So questions? Thank you.
Thank you, Richard. Any questions from our audience?
A lot of thinking going on, hopefully.
Yeah.
I can see Sunanda Roy. Yeah.
Sunanda?
Yeah, thanks very much, Richard, for your presentation. Obviously, being based in Africa and looking out at an African sky, I have a different approach to this. I agree that, that we have to look at systems, we have to look at the political and economic, which I'm guessing your family left. I'm actually in Botswana, and the whole emergency impact of climate change is very real to us right now. I just wanted to say that, yeah, with One Health, it's important that we do look at it both on a global but also on a local basis, because it is very clear that where you have a lot of animals herded together, like the picture you showed of the cattle, or battery farming, the situation with chickens or pigs or whatever, that reality of mass production of meat for European or North American populations is quite different from what many people in Africa are involved with. Cattle tend to be ranch cattle, or they're roaming cattle in open areas. In our context, it's not true that most rabies is from domestic animals. Children get bitten by hyenas, or you can even get a whole range of wild animals get rabies and then pass it on to people who are herding goats or whatever. So in our context, it is very much a wildlife thing. I think that the impact of COVID, for example, again, it's because a lot of people are outdoors, even on socializing on streets, etc. But one thing is very clear, that there's been massive underreporting of infection. I think in a study in Zambia, they showed 100-fold less reporting than notified cases. And I think even in Zimbabwe, they showed that 70% of people have antibodies to COVID. So there was underreporting of infection and probably some underreporting of deaths. But the impact that we're already feeling is more the impact of COVID on other conditions. So maternal health has been affected, HIV, TB, we're already seeing that people are presenting in much later stages. Malaria, people weren't presenting because the symptoms are very similar to COVID. So this has put back advances in our health indicators by a decade, I would say. So, I think we need, I agree completely. We have to look at the system and how COVID has impacted on the whole health system, including the fact that we've lost a number of our senior health professionals from COVID. Yeah. I think it'll be a long time before we recover.
Do you want me to answer something? Okay, you raised some interesting points. So we take rabies, for example. I worked in in East Africa on infectious diseases for 15 years. I was a resident there, working all over Africa, actually, with the African Union, and looking at things like rabies. Now, this idea that there are a lot of rabies cases from wildlife is just it's the narrative, okay, in Africa. But you show me the data. You show me the data. We don't. I know you get occasional incidences, and they tend to be compounded. In other words, it's because it's news. If a bat-eared fox bites a child, it becomes news, right? It's a dog problem. It's a domestic dog problem. And, the evidence that we've got is it's still in Africa, 90%, 95% of it is a dog problem, a domestic dog problem. So yes, of course, a wide range of species can be affected, but the nature of wildlife is that it tends to avoid contact, and it's more cryptic. And of course, you'll get change in behavior with rabies. So you will get these incidents. But I'm sorry, you show me the evidence, and I'll be very very pleased to change my opinion. But I have worked for many decades within the African continent, and I'm afraid that the evidence is not there. Issues around COVID and Africa. Now, we also published we had a study with Queen Mary's University London on lockdown. Okay, lockdown in Africa. We got 6 countries, very comprehensive, and I can send you the link to that if you like. And you're absolutely right that the impact of COVID actually within the African continent is more about that. Actually, it's more about how people responded, and the agendas for COVID have been set not in Africa, they've been set elsewhere, and they've been set in orientation to the crisis that was impacting developed countries. Okay, so if you like, the copy and pasting in response has been very much driven from outside the African continent. And you're right that if you do apply things like lockdowns, severe lockdowns on an already economically stressed community, it's very damaging. Okay, but that's not the virus. So in terms of the biological response of the population to the virus, and underreporting is there, but actually people dying, so mortality, I don't think is that far out, because with all the weaknesses within the African system, and I personally don't think it's that weak actually from my own experience. Most of that data is reasonable across the continent. So it's not that. There's been a lot of talk of, in other words, people just ignore the statement that Africa's resistant to this virus. They say, no, it's just because they're not reporting properly. They must be. They're poor people. They must be. They're vulnerable people. They must be. But I think actually that's wrong. I think it's wrong. And many reasons, probably, not just young people, but I think also probably the co-infections, and that their own immune systems are maybe being stimulated. In the animal field, I can give you lots of examples of this, that under natural conditions where there's much more of a flow of organisms through the community, you get these cross-protective effects in the population that reduces the impact of incoming epidemic-type diseases. So yeah, so I'm sorry, it's challenging for you. And I know Botswana, and of course, climate in Southern Africa is a problem within the African continent, because it's, if you like, the temperate part of the southern world. And therefore, like we are suffering a lot from climate change, it's inevitable that those southern nations will also suffer a lot from climate. Hopefully that answers, it's all about debate and discussion. But thanks very much, Sinan.
Great. Shabir?
Yes, thanks. I think that was really very good presentation. Thanks, Richard. I just wanted to ask the question, if you're looking at, you mentioned the question of resiliencies in Africa, and I was just curious about what you meant by that. I think the comments that have been presented actually are very spot on. I think particularly the question of political economy, and especially the response, the copy and paste, and that's had a more dramatic impact on us in Africa than the actual disease itself. So I think when you say resiliencies, I'm curious, how do you actually judge that statement? I think the other question I have, or the sort of challenge I have, is to think through, like you said, these are higher level type of impacts and perhaps attributions. And I wonder about how do we think as primary healthcare clinicians sitting in a clinic with, a community around us, do we think through these questions of environment and health, animal health, in the context of a primary care community where we are delivering services, and how do we think that through, besides advocacy? Thanks.
Yeah, okay. Yeah, no, resilience, of course, is a very interesting concept. It is one that's, in a sense, borrowed from the natural ecologies. Because if you look at biodiversity, for example, which is really underpins resilience. So if you get a natural system, it's that diversity which helps. In other words, if you have a grassland, if you have 13 or 14 species of grass within that grassland system, if you have some sort of catastrophe, say an infection in a grass that leads to the loss of a grass species from the community, if you have 13, it doesn't matter. If you have 6, it does matter, because you end up, in other words, then any sort of perturbation in the system, the chance of that system changing, actually no longer being a grassland and therefore beneficial to perhaps the animals that live in that grassland. And so this idea of biodiversity loss is so fundamental to the concept of resilience. Now, what have humans done? Humans have simply, destroyed biodiversity. Okay, so they've created conditions now which make it very, very much easier for pathogens and diseases to have impact. So the vulnerabilities, if you like, of the dominant species on the planet now are very much affected by that. So that's the sort of, for me, that's my concept of resilience. Now, the continent of Africa is still remarkably biodiverse, considering it, because the colonial impacts were strong, but they weren't so strong as to destroy. And fortunately, to my mind, the upheavals, of the 1960s, 50s, 60s, 70s, and the, if you like, the casting off of that colonial influence, helped to sort of, preserve that, integrity of the environment to some extent, and the rate of loss and the rate of development was reduced a lot. Now, I know for public health people, this is really tough, to deal with, because particularly public health, and the primary health, because, just because our whole development thinking is based around this, we should be doing this. In other words, we should be agriculturalizing the world. We should be destroying biodiversity because nature is actually dangerous. It's bad for you. It's full of wild animals that bite you. And we should bring the technologies in. So we should bring in all the medicines and the vaccines and all this sort of thing. But what we're missing, in a sense, is seeing the loss of resilience in our society and in our populations. And I can give you loads of examples. So if you go to a developed country, take the United Kingdom, ticks. Now in Africa, anybody who lives in Africa ends up getting bitten by lots of ticks. When I worked in the field, I would have a huge numbers of diversity of ticks biting me. And I was exposed to Borrelias and to rickettsias and to all sorts of organisms throughout my life, from a child born there, and through my working life. And I once or twice had some polyarthritis type conditions, but it was really fairly minor, and I got through it. But in Europe, North America now, something like Lyme's disease, people just don't interact with these things. But when they do, they really get sick, okay? Because they have no immune memory in their system. They've lost this contact with biodiversity. And I know it's very counterintuitive for a primary healthcare setting. Antibiotics in Africa, we all talk about antimicrobial resistance, and we're trying to cut down on antibiotics in Europe and North America and so on. Problem in Africa is people's access. They can't get it. So the world is, in a sense, we're on different sort of, we're sliding at different rates in different directions. But the principle that, use of antibiotics has been phenomenal for reducing, human mortality. But there's a cost to it, because you generate a reaction, if you like, for the microbial communities. And we may have had 100 years of, of freedom, relative freedom from bacterial infection, but, or the consequences. But, we could be back into the same situation within 100 or 200 years, which is daft. I mean, it's just stupid, Does that answer you? But yeah, appreciate the question.
Yeah, thanks.
We have time for one more and then we can go to Simon's presentation. Christian, please go ahead.
Thank you so much. That was a really good presentation, and I really like it. But I got a bit of a little bit confusion of some competing interests between One Health and Global Health when you're tackling the issue of migration. For example, taking One Health from the perspective of zoonotic diseases, vector-borne disease, and to the large scape of ecological changes. And now when you consider the issue, for example, of migration, and it's looking at the impact of climate change, the impact of those large ecological changes on people migrating, you get that I mean, interaction of some global health, international health impact, and then we just don't really recognize One Health on the ground. So it becomes quite difficult for us to incorporate One Health and Global Health when we are in front of those situations. Yeah, I'm here in Africa, and then sometimes we're quite lost. What we're doing now, or we just see the problem and then we tackle it. So I don't know, how do you see the issue of competing interest between One Health and Global Health, and then all of this? Thank you.
I mean, of course, a lot of people confuse these two terms as well. I mean, you know, so global health to me is about improving equity in public health delivery globally. Okay, so that to me, you know, is I don't think we should confuse it with One Health, and I think that principle of be able to, it's a bit like my comments about antibiotics, you know, is that we should have some equality across the world in relation to vaccine, you know, access in the case of COVID and so on. You know, the principle of global health is a really important principle, and we should be doing whatever we can to improve the accessibility to really valuable treatments and techniques and so on within the medical field. Now that's fine. One Health to me is different because it's really saying you can't do everything for humans, because if you do that, you end up undermining humans. And I'm trying to give you the examples, you know, I'm trying to sort of shake off, there's this sort of, sorry to use the term, sort of colonial mentality that somehow one way is right, okay? And that, you know, that people who don't follow that way, they're primitive, and, you know, they've somehow got it wrong. And we need to shake that off. So this whole development paradigm, which I'm afraid Africa still suffers very deeply, you know, that we just have copied and pasted these concepts and ideas, and those people in control are tending to perpetuate that. So it's the same process of degradation of land, agriculturalization of the environment, shifting diets, you know, away from more natural, biodiverse type nutrition to a very narrow nutrition. You know, I can give you so many examples, and somehow we accept it. You know, we all just accept it. It must be right, you know, because those guys, you know, out there in Washington, you know, Peking, whatever, Beijing, they tell us it's right, so we must do it. So I just think we need to shake that off. And so from the One Health perspective, we need to look at our local, so as a local public health person, I would say, look at your local context. What really matters here? Because if you replace, say, occasional vector-borne disease, which can have a very significant impact for road traffic accidents, you will find, I mean, like, let's take Rift Valley fever, all right, which is a disease that is a high priority to the WHO, one of the blue diseases, okay, because when it happens, it can be quite impactful. You might get a few hundred human deaths from it. But you know how many people die on bicycles in Africa every year? You know, but we don't do anything about it, you know? So in other words, we don't get the proportional risk and consequence of development over natural infectious disease cycles within the African continent. So I would just like to see, you know, One Health to get help people to prioritize, you know, what really matters. Is it actually, you know, increasing hamburgers? I mean, the reason our country in the United Kingdom here suffered so much is because 50% of people are approaching clinical obesity. That's what caused the vulnerabilities. And that's because of our diet. and our nutrition system, our developed system. That is very important. To me, the obesity is the issue, not the COVID. Thanks.
Great, thank you. Very inspiring, Richard. I'm sure we can talk about this a bit further as well. And I just see Simon, you asked to swap your presentation with Hans. So I think we have Hans first now.
Alternatively, what I could do is I give my presentation and we have the discussion together afterwards.
Yeah.
That's fine, Simon, for me. Hans here.
Yeah. Okay, so I'll rush a bit because I need to cook for my offspring, and they're on their way home. But I think within 15 minutes I managed to convey my message.
All right.
Is that okay?
Yes.
I'm happy to switch also, Simon, if that's convenient for you. That's of course a bit messing up.
Yeah, I think it messes up our storyline. So I'll keep it short, and then I'll be back for the discussion.
Okay, sounds good.
Okay, let me share my screen. Okay, so yeah, as well, we had a fantastic introduction by Richard about the reasons why One Health matters in the context of climate change, migration and health. And I'm going to dwell a bit more on what we actually mean with One Health, because it's a term, as Richard pointed out, that has been occupied by many communities. It's not always clear whether it is part of an agenda or whether it is part of a concept that we would like to pursue. So I have planned to talk about what One Health is, how it was used in the past in a couple of examples, about 15 case studies where I'll try to summarize, and then I'd like to push it and think about applications at the nexus of climate change, migration and health. So what is One Health? We had at the onset of this NEO program, which was a project to evaluate One Health initiatives, we had a workshop where we were brainstorming what it was all about. And this is the graphic that came out at the end of it. And what I'd like to point out here is that we have basically outcomes that we're expecting from One Health. So sustainability, health and well-being, interspecies equity, stewardship, effectiveness and efficiency. And basically we can invert those virtues and we can call them the drivers. So basically what we're expecting would be, in the negative sense, what would be driving us to engage in a One Health, in a One Health project. And those are in the three pillars of sustainability, namely society, economy, and the environment. Now, what we looked at a bit more was in how does the One Health actually work? So what is a One Health initiative and what does it do? So we have a type of thinking, which is basically system thinking. So global thinking, multidisciplinary thinking, multisectorial, and thinking at multiple scales. We then have a type of planning, which means that we need to have everything associated, like in every normal project, that your aims, your problems, and your funding and resources are associated and not spread across different sectors, where maybe one sector is responsible for infectious diseases, or particularly wildlife is a very nice example where the resources for health prevention are in the Ministry of Health, and the action for prevention should be done by, say, the Ministry of Environment or Ministry of Forestry, or even the Ministry of Agriculture. So there we need to have a coherence in the planning. Then when we talk about working, it is about transdisciplinarity. That means we're not only working across sectors and disciplines, but we're also working with the people. So it's a vertical or a horizontal and a vertical integration. We think across sectors, we work in teams, and we engage for participation. So all these three are what we call the operations of the One Health operations, and they're underpinned by some infrastructure that is essential to facilitate this. So we have the sharing of data, the sharing of knowledge, of resources, and maybe even staff. Then we need to have a learning facility. So we need to have infrastructure that allows learning, so knowledge exchange, but also an institutional memory and some form of feedback at multiple levels of organization, so that we can learn from our mistakes and that we can self-regulate at different levels. Again, it's about an institution, it is about teams, it is about individuals, and at all levels, we need to have that possibility to evolve. Finally, we need to have a systemic organization, which means that we have decentralized decision-making. We have a polycentric organization with a high connectivity, with some form of synchronization and a multidimensional character of all this. So altogether, this gives the approach in the center, and I'll come back to that later, and we'll have the promise, which is what we expect when we think about One Health in general. So often with people, or particularly if the agenda is at stake, the promise is being used to promote an idea, but the approach is then kind of pushed in the background, because that is the part that is really attracting a lot of or not attracting, but actually causing a lot of challenges. So overall, that means that One Health emphasizes that we must decide in the awareness that we're part of nature and that we're not the crown of evolution. And that is where we reflect also what has been questioned just before. Is there a competition between the global health agenda or global health security agenda and One Health? Well, to a certain extent, it is a competition of values. We shouldn't call it a competition. I think it's a negotiation of values that we should reflect on, and we should remember that we are part of nature and that we're not just the pinnacle of evolution. So why do we use a systems approach? It's because One Health problems are usually wicked. Wicked means that they have no delimitation in time or space, or even in terms of elements that are engaged. Infectious disease, for example, they don't know any political boundaries, but climate change also has no boundary except for the planet, maybe, and even there. So there are multiple paths that lead to the same outcome. You can, in this graph, you could take the green, the red, or the blue path, and all those parts are interacting. There are no clear cause and effect relationships anymore, because there's so many paths that could be taken, so no one is in control. And that is something that we like to think of when we think of policy making. When we think of science, we always tend to think that we're under control, that we can do a so-called randomized controlled trial and these kind of things. And if we let go of the assumption that we are under control, the whole thing becomes much more challenging, but it also demands that we take another approach. There's more reasons. In a complex adaptive system, we have variation and novelty that is added to the system over time. We have a form of selection process where some of those emerging processes are being retained and others are being ejected. And overall, this generates a form of behavior with feedback loops, which becomes unpredictable, intractable, and therefore, again, requires some form of feedback and interaction with the living system that is evolving, and us as a scientific endeavor or as a community co-evolving with that system. So system thinking is about bringing many perspectives together and adding a better understanding of what we're looking at. So we need to understand the context of these systems, that the context, although we're looking at a pig in this case, the context will make it a different pig depending on where it sits. We were talking about industrialized production systems. The species is still essentially the same, but the context makes it a different system, and therefore also the pig is different. And that touches on the question of resilience that Richard was talking about just a bit earlier. Then we need to acknowledge that it is all an issue of hierarchies, that we have hierarchies in socio-ecological systems. We have households. We also have individuals. They are a system of cells, aggregated cells, but if they were not organized in a hierarchical system, they wouldn't be functioning. Maybe also hierarchies are just a way that we like to think about nature, or we like to think about life, but it allows us to structure a system, and it allows us to understand it in a better way. So we have individuals, we have communities or households, we then have shires, and finally nations, and the same principles may not be applied to all levels of organization. So when we come to the application of system thinking in One Health, it is reflecting on how and where an initiative is placed in relation to the system. So are we being responsive? Are we early detecting, or are we actually preventing that something emerges? And those are very different places in which we can situate ourselves in regard to a health challenge. We should match an initiative to the dimensions and scales in the system and the initiative. So if we're talking about climate change, we should think about the global scale of this climate change and the emission of greenhouse gases at global scale. Whereas when it comes to the impacts, probably the impacts are very different at the local scale, and that kind of resonated from the conversation we were having before. So to be aware that we have different scales and to try to synchronize our activities at the different scales, that is part of an integrated approach to health. So we're targeting underlying structures of the system. That is what Richard just mentioned about structural One Health. And those structures are then going to give rise to patterns and events. So events are organized in patterns that we recognize. And when we know a pattern of emerging diseases, we then understand it better so we can be faster, but we still can't change the fact that they emerge. Whereas if we understand the underlying structures, then we get into basically in a situation of activity or power where we can actually change the conditions. So we should consider development over time. We have delayed effects, particularly the larger the system is. And I mean, if you're talking about climate change, you know that delays are massive compared to the delays when you talk about economic consequences of some activity. And those delays have an impact on how decisions are made. So we need to balance the different time aspects in a complex system. And again, feedback is also an important feature that we need to recognize, that feedback happens slower at larger geographical or ecological scales. So we fundamentally should also consider the three pillars of sustainability, namely the ecosystem or the environment, the economy, and the society. So how was that used in the past? To help you orient you through those case studies, we did a so-called spider diagram where we analyzed the working, the thinking, and the planning on the left side, and the learning, sharing, and systemic organization on the right side. So here you would have two initiatives that were evaluated. One was a bit stronger on the operational side and rather weak on the infrastructural side, whereas this blue one would be quite weak on the thinking, working, and planning side and very strong on the sharing side. So this is a way that we could evaluate this knowledge integration capacity of those systems. So as you can see, you have on the left upper corner, you have the operation, so the way that we operate, we think, And on the left-hand side, you have the infrastructure that is underpinning that kind of operations. We also have a different way of thinking about it. The same features would actually fit to the project lifecycle. So we think about the project lifecycle, we have an agenda setting, a decision-making, a planning phase where planning and thinking would fit into, so One Health planning and One Health thinking. Then we will have an implementation phase where it's about working and organizing people. So working and organization would fit into the implementation phase. And then we would have an evaluation phase, which is about learning and the sharing of data. So I'm just giving you this so that we can have a look at these 15 initiatives. On the top, you have a couple that are international, so primarily Africa and Asia. And then on the bottom, you have more European programs. They were not all evaluated with the same evaluator, but I think the picture shows us already quite some information. So if we think about the operations, we can see that those three columns, they're dark green or darker green. What that means is that they have the scores that were in the top 45 percentile or the three top quartiles, and the light ones, they're in the bottom quartiles. So that means the scores for the thinking, planning, and working were rather high, whereas if we compare that with the infrastructural scores, there was some stuff in organization, but sharing and learning was largely neglected by most of those programs. If we look at the policy cycle perspective, the agenda setting was usually quite well fitted and quite well organized and reached high scores, whereas also implementation was well organized, and in the end evaluation was neglected. So this is just to give you an idea that evaluation, and particularly learning and sharing, is something that we struggle with, and that resonates with somewhat of our general narrative of competition and competitiveness among different sectors, among different interests and different ideas. So if we apply this now to the nexus, I think there's a couple of things that we could retain. There's the thinking in events, in patterns and structures. So I think if we think about events, you have your migratory events, your migratory triggers. That will be something that changes then your local situation. That event may have a succession of other events in the other elements. We can see those as patterns of a larger set of events, but then we should think about structures, and climate change is a typical situation where we definitely need to address the structures before we look at what events we're actually dealing with, but we could do the same thing with migration or with health. So we should start to use these ideas more systematically when we address these problems. The thing that I found quite interesting thinking about scales was that when we think about climate change, we think about the global change, and we don't tend to think too much about continental or local impacts, in the sense of how there is a local possibility to deal and to mitigate. When we talk about migration, we think about populations. We again don't think too much about the global, and we don't think too much about the individual levels, which are the other scales at which we may have another way of dealing with the situation. And when we look at it in an integrated way, we may see some opportunities to improve the way that we deal with it. And when it comes to health, we tend to think of health at individual level, and we tend to neglect populations or even ecosystems as a consideration of what health could actually mean and how health is integrated in the larger context. So those are some thoughts, and I'd like to trigger a reflection, and namely on how research actually exacerbates climate change, migration, and disease. So that is one probably of the most important things that I have learned from system thinking, is to always reflect, how do I cause that system? What do I do in that system? And if there are things in the system that I dislike or that I would like to change, I first need to gain a total clarity on what my role in the causation of this problem actually is. So if we think about climate change as researchers, for example, we're traveling a lot internationally. We have a lot of flights. We cause some greenhouse gas. So how could we, what is our role there? How do we contribute to migration? For example, Richard just talked about the narratives. We are shaping those narratives in science, and science is definitely not value free. So the values of science, they may have contributed to a larger or smaller extent to the migration as it is occurring. And finally, also disease, the way that disease is perceived, what is considered a disease, and how strong those diseases are tackled and dealt with is also finally a result of a scientific discourse. And with that, I'd like to close my conversation, my presentation. Obviously, I need to acknowledge a lot of people who have contributed to those thoughts. I'll be back for the conversation after Hans's discussion. If there's any urgent questions right now, I'm quite happy to take them, but otherwise I'd leave you to a conversation among yourselves.
Thank you, Simon. Yeah, if there's any question right now, we can take maybe one or two.
Let's leave Simon to go and feed his children, and then we'll take it later.
Perfect. All right.
Thanks a lot. I'll see you in 10.
Yes, thank you, Simon, for this very interesting presentation and reflecting a bit more on methods. Hans, you're up next. Our final presentation. Hans is a political scientist at who has also a PhD in environmental science at the University of Antwerp. And Hans will talk a bit more about complexity, the need for maybe another science, and how we can use the One Health approach to deal with complexity and transformation. Hans, please go ahead.
Thank you very much. I will try to share my screen. Let's see if it works. It's this one. Can you see this?
Yes.
All right.
Just need to put it in presentation.
Yeah, okay. I will do that in a minute. So I'm working at the health faculty at the University of Antwerp, especially at the General Practitioners Department and also at the Global Health Institute. I also work at the Biodiversity Platform, which is an initiative that works in relation to biodiversity in Belgium. There I mainly work on the linkages between nature and health. And so I go to from right to left now. I also am involved in NEO, which has been mentioned, and also I'm co-coordinating the Belgian One Health Network. So for all the Belgians, we have a big event on November 23rd, but please send me an email if you want more information on that. I show you this because I had much more slides prepared, but listening to the colleagues just now, I propose to skip them, so I will just give you a quick overview of a lot of images of complexity that I collated for you, but they will be distributed later. I understood the presentation, so you can, at another instance, take your time to look into these. So what I will do is focus a little bit on the critical approaches to complexity. Before, I would like to introduce two methods, expert elicitation and multi-criteria decision analysis, that at least were inspirational for me to use in dealing with all these complex issues in scientific, but also policy and practice-oriented manner. So critical complexity. I think a lot of the complexity thinking is still building on what originated in 1984 in New Mexico, I think it was, in the establishment of the Santa Fe Institute in the United States. And this complexity thinking that originated there, among also, of course, it originated in other spots in the world, is still a bit dominant, I think, and it heavily focuses on mathematical approaches, it's big data approaches, and focuses a bit less on philosophical, normative, and epistemological thinking and questions in relation to that. And Edgar Morin, the complexity philosopher from France, also for that reason calls it restricted complexity, or I would call it a restricted view on complexity. And I think this table that I took from a publication from Rosenhead already from 1989, so quite old already, actually nicely illustrates this divide, you could say, in complexity thinking, that these more Santa Fe type of approaches, these big data mathematical approaches, could be labeled as traditional paradigms, and they try to look from a very objective optimization perspective. Data demand is of huge importance. The judgment, the interpretation of the data is very much science-oriented, consensus-oriented. The role of societal actors is rather as passive objects. Decision-making rather top-down, single decision-makers, and uncertainty is something you should try to abolish. Whereas alternative complexity paradigms more try to get an overview of several potential alternative solutions that could have trade-offs on several complexity or system dimension, of course, so a bit broader view on reality, data demand being of less important, also having a more active role of societal actors, so resonating with the transdisciplinarity approach that was just presented, also having a more bottom-up, multiple decision-maker perspective, and also accept uncertainty as part of what we just have to deal with. Now, the people that I've been in contact with, at least when working in my own PhD endeavor, could label themselves as critical complexity thinkers. That's on the left, Paul Sellier, a South African philosopher who unfortunately died at a way too young age. I think he was 56, but very inspirational one for me, and also for Harry Koeneman on the top right. He's a Dutch philosopher, and below him, Edgar Morin, also very interesting philosophy, complexity thinker from France. I want to give you a few quotes from Paul Sellier just to illustrate this more critical thinking on complexity. Is to realize that we have more than one description of a complex system. So it all matters on how you approach it. There are different ways, different degrees of complexity to be taken on board. You have options to choose from in how you try to get your grip and formulate the complex system. And the knowledge about this complexity is provisional, simply because of this complexity. It's impossible to have a full overview of all the elements. We always have to somehow simplify it. We have to make choices in what we take into account and what we don't take into account. So it means that we always have some aspects of normative and ethical issues to take into account. And that final claims about this complex system are very difficult to reach. Also, it means that it's easily criticized for that reason. Like it doesn't really matter which approach you take or which framing of complexity, but of course, there's still this still doesn't mean, according to the saying of Paul Frier, that limited knowledge is not necessarily the equivalent of any knowledge. And modest claims are not per definition only relativistic or weak, but they should be modest in the sense that there should always be an invitation for dialogue, a bit what Simon also addressed in his presentation. And it also means that we, of course, we can know things about complex systems and we can make strong claims about them if we have good science developed. But we should always be a bit modest in the sense that we will never have the full picture, that we will never have final claims. So it should be part of an ongoing and collaborative open dialogue process. So that was a little bit about a more critical view on complexity. Now I would like to introduce you with a method that I've been using called expert elicitation or expert consultation, which could be helpful in addressing these complex challenges. And I do that based on an experience that I had within what some people call the IPCC for biodiversity. Maybe not all of you have heard of this IPBES process. It's similar to the IPCC process for climate, but it started later. It's still relatively young compared to IPCC, but it has been ongoing for quite some time now. And it's also a UN process in which governments, almost all governments in the UN system, actually try to work together with scientists in addressing these important challenges. In this case, mainly departing from the biodiversity ecosystem challenges. This is a depiction of how they try to frame the context, kind of theoretical framework for how they want to approach all the elements that matter in this perspective. And I think it highly is of a big tolerance nature, which is, I think, quite important to mention, that they are open for different approaches, also from local indigenous communities to addressing these questions. We have big challenges, of course, in the sense that nature relates to a lot of other environmental and health issues, of course, linking to climate, linking to human health. So this is an overview of what they call the nature's contributions to people, which are underpinning, as they call it, the quality of life in many respects. How do they try to deal with, of course, the challenge of complexity and of developing but often limited understanding of these system aspects? How do they try to deal with uncertainty, scientific uncertainty? And this is a kind of a confidence language that they try to use to label scientific findings or publications about scientific findings, which they assemble to base their advice to policymakers on, a bit similar to what has been used in the IPCC. So it goes from a low level of agreement between scientific experts to high agreement. And it goes to a low quality of and quantity of evidence to high robustness of evidence. And you see here 4 categorizations of scientific evidence that's used in this process. Now, I was getting involved as a lead author in one of the chapters of the regional assessment for Europe and Central Asia. And being a non-biologist, I mean, these processes are, of course, dominated largely by biodiversity and ecosystem people. I thought, how can I bring health on the agenda? Because they hardly ever talk about health. health of humans, but also health of animals, or even the health aspects of the ecosystem in relation to them. They are hardly addressed in this community. So how to bring this to the agenda? That was a bit my mission in this process. And together with 2 people, we were only with 3 in getting ourselves organized. We thought it would be wise to build on the 2015 publication of WHO and Convention of Biological Diversity, which gave a big state of knowledge review overview of all the knowledge that has been developing in the past decades on the linkages between biodiversity and human health. I would recommend you to read it or to have a quick view. It tackles also a lot of elements in relation to climate change, also in relation to, of importance for human health. Very recommendable. And building on this report, we constructed our own literature review approach, focusing on this long list of relevant topics. So you can imagine that the 3 of us really took up a big challenge to get all this scientific knowledge together. We managed somehow, but how to make sense then of interpreting all this data? If you think back on this square box system that I just showed you, that's used within IPBES to characterize the state of evidence of scientific research, it's of course of great complexity and a big challenge for only 3 people with all their own compartmentalized limited knowledge to have a good view on how to interpret this body of science. So what we thought to organize was this expert elicitation. So we addressed many experts that we knew in our own networks, including NEO. I think Richard, who's on the call, was also taking part in this. I don't know if Simon was involved, but could well be. So several of our NEO colleagues were involved. And what we did is we first, and we also contacted, by the way, the authors of the publications that we included. And then through a snowball outreach approach, we started consulting these experts with synthesized texts, text that we could bring together all these topical issues that I just show you in this list. And this synthesized text, we asked them to characterize with this evidence characterization approach that I just explained, which is being used in IPBES. Also, we supplied them with already a draft list of key messages coming out of this body of knowledge in order to work towards not only describing the knowledge, but also working towards lessons for policymakers, which we could use later in the process in the dialogue within the UN system of IPBES with the governments. And then, of course, we would collect all these individual responses to our invitation to the experts and collate it all and share it again with the whole group anonymously, of course, in order to give all the opportunity to take knowledge from this collected body of experts, and also to give some extra view on this. And also we gave them, we asked them to rank the importance of the key messages that we have been working on. Now, a quick overview of the number of people we invited. We actually had let's say, a general health assessment part and also medicinal plant assessment part. That's too much detail for now, but just to explain you this graph. We invited 65 experts in total, and on the first questionnaire, we sent out on the general health part, which I will limit myself to now, 36 experts internationally responded, and 24 also responded in the second round. Now, who were these respondents? Largely, they came from the scientific realm. It was difficult to get indigenous local knowledge holders on board, also a bit more difficult to get policy experts, policy representatives and stakeholder organizations on board. So within our, we did our best, of course, to involve also these groups, but it was a bit more difficult to engage them. They came from quite a diversity of backgrounds, including biomedical research, food and nutrition, medicinal resources, public health, etc., infectious disease. So that was a nice diversity, which was very helpful with the diversity of key topics that we dealt with. And I think when we look at the region, of course, the majority came from Europe. This was also a European Central Asian assessment. So that's quite logical, but we also had some experts who also had their geographical background or expertise more on the global scale or outside of Europe. So this for your information. This is how it looked in the end. This is one of the outcomes. So we looked at the importance of biodiversity for human health in the broader sense, and we asked the experts, how do you judge the scientific knowledge that we brought together? Is it well established? Is it established but incomplete? Is it unresolved, or is it really inconclusive? And of course, we also gave them the opportunity to state that they actually didn't have a clue because it wasn't beyond their expertise. Now here you see that there's a large consensus about this specific topic among these experts, to note that it was well established, and yeah, also a considerable group considered still additional knowledge was needed. Now, if you look at another topic, which is the role of biodiversity in relation to the potential dilution of infectious disease risks. I should not explain this to you. Actually, Richard or Simon should explain this. They are much more knowledgeable. But this dilution hypothesis points at more biodiverse ecosystems would actually dilute the infectious disease risk for humans in contact with this ecosystem. But of course, it could also be the opposite. It could also have an amplification effect. And I think both of these theories are quite common and have their own probably expert groups, but also they are noticed in the ecosystems in different respects in research. So here you can clearly see that the experts also acknowledge this, that there were quite some difference of opinions, difference of view. So you could see this diversion of different distinction between these two communities on the dilution and amplification effect in our response here. Now, what in the end was our success? That was, of course, what we were aiming for, getting health on the agenda in this important report on the United Nations level. And in the end, we succeeded to include attention for health at the highest level. So we did a good job in that sense. So it was all quite worthwhile. And this approach, even if it was going beyond a more traditional literature review approach, this expert elicitation approach was quite appreciated and quite functional in what we intended it for. So that was positive in that sense. I'm not sure how I'm doing in time. I cannot see my time on the screen here, but
you can continue for
okay,
like 5 minutes.
I will do that.
Don't worry.
Okay. I also would like to introduce you to multi-criteria decision analysis which is also a very nice non-monetary evaluation method, which is very helpful in embracing, combining, and structuring incommensurably diversity of information, coming from qualitative and quantitative data, as well taking into account uncertainties, diversity of opinion, also among experts, diversity in actor perspectives, including stakeholders, and diversity in assessment or decision-making criteria. And it's very functional in supporting deliberation, decision-making, but also in communicating and legitimizing the reasons for taking certain decisions. This also nicely connects with the diverse valuation perspective that's quite common in IPES. I don't have enough time to go into details, but it goes way beyond the rather limited economic cost-benefit approach, where they mainly look at things that are easily put into monetary terms and often excluding other variables or aspects that are of great importance, especially when we think about health. What we always try to do is to show that multi-criteria decision analysis should be part of a broader process, a process which starts with deliberation, which is about defining the joint journey that we take into, that we embark on, defining policy alternatives that could be important to consider, to also define decision-making criteria, and this can all be then fed into a multi-criteria analysis step, but this is not to calculate the truth, as they say, or objectify what's best, but simply helping in structuring and supporting stakeholder deliberation, which should be in the end the most important aim of such a process. Now, how does it look like? I will just quickly give you some view on how this can look like. This is how it looks when experts assess different environmental polluters or pollution elements in our environment in relation to health risks, policy feasibility, and social aspects. And you can clearly see that some of the environmental health risks, like the purple, the pink one, sorry, on dioxins, is clearly scoring quite irregularly across these different criteria. So it means that it's important, if you consider policy feasibility to be very important as a basis for your decision making, then this one scores high. But if you think of health risks, you could consider other environmental health polluting issues to be more important. When we think about stakeholder discussion, building, looking at these outcomes of expert judgments, expert assessment information, we would ask them not to do the assessment themselves. That's, of course, a bit more an expert job. But we would ask them indeed the question, which of these criteria do you think is most important when making decisions? Is the health risk more important, or are the social aspects more important, or is the policy feasibility, can you really do something as a policymaker, more important? And you see here that in this exercise, the different stakeholder groups actually had quite different views in what is more important to weigh, to take into account when making decisions. Now, what does this mean for One Health? I will skip this one because it builds on the previous slides, which I didn't show, but this is just an example. It's just an invented example of multi-criteria decision analysis framework where you see as criteria on the top the health impacts, and that could include also the animal health impact, then the environmental or biodiversity impact, economic impact, social impact, and practical feasibility. And then a couple of, in the blue column, policy options. So what can we do about the problem at hand? Do we leave it as it is, business as usual, or do we take one of the 4 potential interventions options? And here you can see that if you look at these different criteria in relation to these policy options, that they score quite differently on the different criteria. So it means that there are no obvious prioritizable interventions if you have such a scoring grid, taking into account all the information in relation to these policy options that could objectify a decision. So it means that this kind of analysis, so we can calculate consensus rankings, we can also incorporate weighing of the different criteria that could help in structuring this complex puzzle and can be supportive to solving these issues. So this is one example. I have a question for you, for the group, then I will stop and leave the floor to you for questions and discussion. A question that I often struggle if we talk about important and urgent issues, and they are clearly at hand in this network, also in One Health, when and how do or can we know enough about them in order to act responsibly or sensibly? And the second question I have is who decides and how do we organize this, where and when? And I think this is both a scientific question, is this more laboratory oriented case control type of science most relevant, or should we indeed look for new ways of developing knowledge that is much more fitting to these complex contexts, to the local context also, where we have urgent issues to tackle, where different stakes but also different scientific angles can be taken. So thank you for this. I will stop sharing. Just my last slide, so you can see my contact details, but these will be in the presentations that will be shared with you later. Thank you very much for your attention.
Thank you, Hans. It was really interesting to see a bit of the process. I had a couple of your projects. All right, are there any questions for Simon or Hans, or maybe going back to the first presentation as well?
Please forgive me, Richard, for my clumsy explanation of the dilution hypothesis, and also to Simon, please correct me if needed. You are the real experts on that.
It's like everything, you know, there are all sorts of angles, but no worries. I think it was very good.
I see in the chat there's still a little bit about the process at looking at things such as COVID, looking at it from a population level, considering upstream policy solutions rather than focus on individuals. And I see Patricia, I think she left, says that One Health has a potential to facilitate this with a transdisciplinary approach. Any input on that from our presentations?
Well, I think the utility of this systems approach is really that we become aware of those different perspectives, and that we don't shy away from the fact that they might be contradictive or in competition. And one approach that has been advocated in many contexts when it comes to these kind of problems is that we get away from the optimization idea. It's another narrative. Optimization is a concept that has its origin in mathematics, where it goes to estimating parameters or something like that, where you have a closed system in which you can find an optimum per se. Now, if we talk about complex adaptive systems, these are no mathematically closed systems, for one, and secondly, they have more than one optimum or optima, and maybe it's even an area that is much larger than just a point. So optimization assumes that there's one point where everything is satisfied, and under this assumption, we are trying to solve our public health problems. And when we get away from the idea of optimizing, but actually go towards satisficing, so that means that we are trying to find an area of operation in which everybody's basic needs are fulfilled, but we are not optimal for anyone, then we must come much more into the area of something operational that is also acceptable and that is basically also more sustainable. Because in the process of optimization, because those systems are getting too complex, one reduces the system until you have a number of variables that allow you to do that optimization, rather than keeping the variety large and just accept that you can't find an optimum. And I think that's somewhere where we also as scientists need to change our thinking.
Mm-hmm.
To ask a question back to you, Simon. I'm of course a poor, lonesome social scientist, so I'm really not a real scientist. You are the real scientist. Does it mean that science should change? Do we need another science? I sometimes wonder. And if so, what is it? How does it look like? What are the treasures of that science? Except, systems approach, etc. Is it more a talk science? We discuss about everything endlessly. Is it purely relativistic? It doesn't matter what you say. How do you look at this?
Well, I don't think. I think our reductionist approach has got absolute benefits. I mean, analysis of a problem and analysis of a reduced problem is absolutely essential in the process of science. I don't think we should throw that overboard. But what we should now move this step ahead and try to reintegrate that reductionist knowledge into the larger context. And that's where the challenge comes, that we mathematically are reaching an area where those simplified methodologies that are so nicely so nice, orderly, and where we can really observe what is going on. That's where we reach the boundary of those methods. And I think that's where we are. That's where we need to move forward. We need to extend the fan of options by those methods that allow us then to integrate those different knowledge systems, those different belief systems, those different, and I really think it's a matter of, it's not if or, but it's an and question, and it's not a critique in the existing, but it's maybe it's a realization of the boundary of the existing. And an extension of that boundary towards methods that supplement this to make it applicable to the real world challenges.
Mm-hmm.
I'll say very short to add to this discussion. I think One Health is just a platform where we can break down these boundaries, break down the walls between people. I'm a scientist, and so to me, it's about evidence. And what I know about and what I have evidence for, I am confident I can argue about. But most narratives that people hold in their brains are of issues that are outside their expert opinion, are just opinion. And they're often driven by power and power hierarchies. So One Health provides a situation like now, and I've been having a great sort of chat discussion individually and so on. I don't want to create or be insensitive to people, which shows that often our evidence base, when we talk about, say, if you're a public health person and you talk about an animal health issue or a wildlife issue, actually you don't have the evidence base. So you need to sit with people. It's like, if I sit with somebody, an indigenous community in a country, who've lived and worked with biodiversity and understand the issues around it, I got to listen to those people. I don't go in saying you're primitive, you shouldn't, you don't know, you haven't got a Cambridge degree, therefore I go, you got to listen. And One Health to me gives the opportunity for these hierarchies to be put to one side. In Africa, the veterinary profession is very low in the hierarchy. Okay, if you work with animals, you're really low in the hierarchy. You might be really smart and really understand infectious disease problems, but when you go into a public health environment with medical people trained, you have a big political disadvantage because they don't listen to you. You can tell them what's going on, but they'll bring their public health view, which has been derived from other narratives. So these are the challenges, and it goes across, and my social science colleagues, you'll understand this. So One Health to me is about this interaction, getting this interaction and breaking boundaries. Thanks.
Sunanda, and then we have Shabir. Please, Sunanda, go ahead.
Yeah, thanks very much. And thank you, Richard, for that last comment, which is really along the lines of what I wanted to say about the whole issue about complexity theories. And in a way, it's trying to look at narratives. Well, you all know that anthropology, looking at narratives and the context, you see that there are different ways of looking at that story, and by its nature, it's complex. And it's bringing those ideas or looking at those ideas and saying, how does it fit with the narrative in a particular context? I can't do this without looking at stories. So if you take, for example, we've got this possible disaster looming in the Okavango. Okay, there's an American-Canadian organization that's exploring for oil and gas in northern Namibia and Botswana, promising people that this is going to bring billions of dollars of wealth and billions of liters of fossil-based fuels. Okay, so they produce evidence of having consulted with local people, where they say all these local people are really keen on this because it's going to bring wealth. They can also, the politicians will bring evidence saying this is going to help us develop our countries the way countries in Europe and North America develop their countries through discovering oil and gas, etc., and using oil and gas in their industrial revolutions. Then you can also bring evidence from people saying, I'm on the outskirts of where they're doing the exploration. My water supply has been contaminated. This is all groups of people that are sitting and talking to different people and giving their narratives. And you can put it together as evidence, but they have conflicting views based on what their needs are and what their motivations are and what their agendas are. Now, this is in one place, but you could see that over the last 200 years, this is a situation that's been played over and over in different ways. And coming down to the core of this, of saying who is going to benefit, is very difficult. And we're not resolving it because, and this is another worry on my part, that many of us, I'm a public health physician, so many of us are so busy trying to put out fires. You know, the fire caused by Ebola, the fire caused by COVID, the impact of COVID, that we don't have time to sit down and say, how does this pan out as a complexity theory? How does this help us with decisions, as well as whether we have the power to influence our policymakers, etc., to actually respond to all of this. So it's very difficult for me to hear this coming from Europe, where it doesn't grapple with the actual reality of what people are trying to cope with on the ground. Thanks.
Happily, One Health, as far as I'm concerned, started in South Africa. So it might be adopted by the Europeans in Europe. But no, I think this idea came very much from Africa, actually. So yeah, so I'm sorry to contradict you there. But of course, everybody thinks things come from a certain area, from their perspective. But no, I think One Health does provide this opportunity. If we can keep it as an open platform, if we can keep it as an open paradigm, and we don't let it be hijacked in a sense by, as you say, particular agendas, particular individual groupings who want to use it for their own purposes. Yeah, so that's, to me, that's the fight really, is to keep that open dialogue. Thanks.
All right, Shabir, and then Christian, maybe try to keep it a bit
Very
shorter.
Yep.
We're almost running out of time.
Yeah, I think really I appreciate this. I've really enjoyed the webinar and the discussions. I think we'll certainly be picking up on it. And as a clinician leading an effort which is trying to bring together primary care actors across Africa and doing fairly well in bringing them across, I think the question that you're raising, we've actually been talking to the question of complexity theory, because in terms of the organization of primary care, there's very much this very hierarchical thinking, reductionist thinking, and we've said that there needs to be a change. And I think we must listen to whatever wisdom there lies across the world and take what we can. And I found great value in what has been presented, obviously from your perspectives that you have. I do think that One Health is brought in, I think this CliMigHealth is about that, thinking how we work, at optimal levels, as has been said by Simon about, working with the climate and the animal, the environment, including animal health. And I think that what we have to do is look at, to me, as Africans, how we can use both, the hard science, but also the soft science that we think are available, and be able to convince the stakeholders. And I think that's not just in Africa, but globally, because I think, the political economy spoken of is exactly the challenge in Africa. And I think it's going to be very easy, and it has been very easy to manipulate the agenda that Sunanda pointed out. And I think as Africans, we need to be able to think ahead, despite our challenges, as to how we can affect that discourse. And I think we shouldn't feel despondent or helpless. I think the power of truth is power. And I think we need to look at power in all sorts of other places than the formal power that exists around the world. And I think that, thank you very much. I've really found it very, very helpful. Thank you. And I hope we can get the slides shared and that we can look at collaborations as well. So thank you and well done.
Okay. Thank you for that, Shabir. Christian, did you want to have the last question of this workshop? Are you still there?
Just noticed that there is no time. It's just for a minute.
Yeah.
I think we can conclude for that. It's okay. Thank you.
Okay.
Maybe I'll send my question to the two last speakers. Thank you.
All right. So I think we're wrapping up here. Yeah, we'd love to thank Richard, Simon, and Hans for this interesting presentation, and also spurring the debate on this. I think we definitely have much more to talk about and to reflect on. So who knows, we'll have a sequel of this and we can work with this further along. I will send the presentations to everyone and also send the contact details of the presenters. If you have any more questions for them, you can reach out to them through email.
Thanks for the opportunity, Charlotte. Much appreciated. Thanks, Simon. Thanks, Hans. Thanks, everybody. It's been great to meet you.
Yeah. Absolutely. Okay,
Thank
bye-bye,
you.
everyone.
Yeah, bye-bye.